All right, let's get right into it. Welcome to this explainer. Today we are diving deep, and I mean really deep, into a masterclass on decoding the rigorous managed care plan performance metrics set out by the SASB standards. If you're someone who loves structure, clarity, and just cutting straight to the mathematical truth of how a business operates, well, you are in the exact right place. We're going to look under the hood of healthcare operations to see exactly how real-world performance is quantified.
Okay, let's dive into this. We're breaking this down into 5 quick sections today: valuing plan performance, calculating enrollee retention, tracking reversed denied claims, measuring enrollee grievances, and finally, the big picture.
Starting off with Section 1, Valuing Plan Performance.
Now, when we talk about plan performance in managed care, we're not just talking about, customer surveys or warm and fuzzy feelings. We are talking about strict, quantifiable drivers of enterprise value. And to understand how to actually measure this, we rely on our authoritative source for this explainer, the SASB standards, which now sit under the ISSB framework. Specifically, we're focusing on the healthcare sector standards for the managed care industry. What's great about these standards is they give us strict, standardized accounting formulas. They completely strip away the marketing spin and force organizations to report their data in a totally uniform, comparable way.
So, why does this level of standardization matter? Well, in managed care, a plan's performance across key metrics, things like responsiveness, complaints, and voluntary disenrollment, isn't just some operational footnote. These metrics can directly impact reimbursement rates and even bonus payments in certain jurisdictions. Simply put, an organization's reputation for high-quality care, measured through these exact indicators, dictates its market share, its margins, and ultimately, how investors understand the way it protects its enterprise value.
Moving right along to Section 2, Calculating Enrollee Retention, specifically SAS metric HC-MC250A.2.
Let's see how this actually builds into our first hardcore metric. At its core, the enrollee retention rate is just the plain English concept of keeping customers within your specific plan structures. But measuring this isn't as simple as just looking at total headcount year over year. A total headcount can actually be artificially inflated by a massive influx of new sales, which might be hiding a terrible retention problem underneath. So the SASB formula is designed to isolate true retention.
So the crucial point here is how this mathematical formula is structured. For our numerator, we take the total number of enrollees at the close of the reporting period, but then we strictly subtract the new enrollees added during that period. We only want to look at the people we started with who are actually still here. Then, we divide that by our denominator, which is the total number of enrollees at the close of the previous period. But wait, we have to subtract a few highly specific categories from that baseline to make it fair.
These subtractions in the denominator are what I like to call the gotchas, the strict exclusions. Think about it. If a health plan fires a customer because that customer committed fraud or intentionally misrepresented material facts, well, it makes absolutely no logical sense to penalize the plan's retention rate for losing them. I mean, you don't want to retain fraudsters. Similarly, if a health plan provides insurance for a corporate employer and that employer's staff naturally turns over, like employees quit or get fired, the health plan shouldn't take a hit to its retention rate for that either. So the formula smartly excludes these involuntary terminations and employer-sponsored attrition events to reveal the true voluntary retention rate.
All right, on to Section 3, Tracking Reversed Denied Claims. This is SAS metric HCMC250A.3.
This metric is a really fascinating look at the friction points of managed care. By definition, it tracks the percentage of claims that the plan initially denied, which the customer then appealed, resulting in the plan actually reversing its decision and finding the original denial invalid. What we're really measuring here is the plan's initial accuracy as well as its responsiveness. If this percentage is high, it essentially tells investors that the plan is frequently making mistakes on the front end by denying care or payment that actually should have been approved in the first place.
Let's walk through the exact journey a claim has to take to qualify for this calculation. Step 1. The claim is denied. This includes both denials right at the time of payment and pre-authorization denials. Like when a service is deemed medically unnecessary before it even happens. Step 2. The customer appeals. And note, the standards specifically state that formal complaints related to the denial of coverage also count as an appeal here. Step 3. The entity reviews it and deems the denial invalid. And finally, Step 4. The decision is officially reversed. The math here is incredibly targeted. The numerator is the number of claims denied, successfully appealed, and reversed. But check out the denominator. The denominator is not all denied claims. It is strictly the total number of claims that were denied and appealed by enrollees. This is vital. We are calculating the success rate of the appeals, completely isolating the universe of claims where the customer actually pushed back. Now, what's really interesting here is the strict set of accounting rules that govern this formula. First, you have to exclude simple billing errors that were just appealed, resubmitted, and paid out. Those are administrative hiccups, not true coverage disputes. Second, a partial claim denial counts exactly the same as an entire claim denial. Third, like we mentioned, pre-authorization denials are included. Fourth, and this is a big one, you only count appeals that were actually resolved during the reporting period. Ongoing unresolved appeals are completely ignored for this specific reporting cycle. And finally, if a customer files multiple appeals on the exact same claim, you consolidate them. They only count as one single claim in your calculation.
Let's move to Section 4, Measuring Enrollee Grievances. SASB metric HC-MC-250A.4.
Moving into our final specific metric breakdown, the SASB definition of a grievance is incredibly specific and surprisingly broad. It is any complaint or dispute expressing dissatisfaction with how the entity or a delegate of the entity provides healthcare services, and here's the most critical phrase, regardless of whether any remedial action can be taken. Basically, even if the plan literally cannot fix the issue, if the customer complains, it still counts as a grievance.
10,000. Keep this baseline number in your head. Unlike the previous metrics, which gave us clean percentages, the grievance rate is normalized. You do not present this as a simple percentage of your user base. Instead, it must be calculated and reported as a rate per 10,000 enrollees.
Looking at the calculation, your numerator is simply the total number of grievances reported during the period. Your denominator is where that 10,000 comes into play. You take your monthly average enrollees and divide it by 10,000. And to be perfectly precise, monthly average enrollees isn't just a guess. It's calculated by taking the total number of member months, meaning one member enrolled for 1 month equals 1 member month, and dividing that total by 12.
And this brilliantly illustrates just how wide of a net this metric really casts. Look at what qualifies. It isn't just written legal disputes. A complaint registered orally over a simple phone call counts. Grievances include issues with the timeliness of getting a service or access to it. It includes complaints about the appropriateness or setting of a service. It even includes complaints from a patient claiming that a covered health procedure during their treatment just didn't meet accepted healthcare delivery standards. It captures the entire spectrum of enrollee dissatisfaction. Finally, Section 5, the big picture. Now that we've broken down the math and the rules, let's synthesize how these three rigorous metrics combine to tell a much larger story. What we've really been talking about today is translation, properly calculating true enrollee retention, isolating the rate of reverse denied claims, and tracking normalized grievance rates. All of this transforms messy, highly emotional human healthcare interactions into standardized, comparable financial data. It allows investors, regulators, and the organizations themselves to see past the flashy marketing brochures and understand exactly how well a managed care plan is truly functioning at a systemic level. Which leaves us with this final provocative thought to consider. Do your reporting models actually capture the true story of your plan's performance, or are they hiding behind less rigorous math? Thank you so much for joining me for this Explainer Masterclass. I highly encourage you to take these strict SASB standard formulas and apply them to your own data practices to see what the math really reveals. Keep learning, keep analyzing, and I'll catch you in the next one.